The next speaker on stage is Dr. Ivan Peev, Head of Implantology at the Dentprime Clinic. His great surgical know-how is unbeatable. I think on a normal day, he's placing about 30 implants. I had the chance several times to take a look over your shoulder, and when you place or perform a full arch, as we saw him already before, it's just amazing. It looks so easy, as if everybody could do that. It's very similar. And I'm very excited to hear from your presentation. I'm very happy to welcome Dr. Ivan Peev on stage. Hast du einen Klicker?
So thank you very much for your kind invitation. It's so great to be here. We are not only the biggest three-shade network with 75 intraoral scanners. We are not only more than 400 employees. We insert around 10,000 implants in a year to achieve around 500 new smiles each month. These numbers may be difficult to imagine, but they are our reality. We are Dentprime. My name is Ivan Peev, and I am the head of the implantology department of the Dentprime Dental Clinic. We are located in Varna, Bulgaria, on the Black Sea coast, and we are over 15 years in business. The requirements for our work are a little bit different than the conventional dental practice. Of course, we do also fillings, teeth cleaning, single crowns, bridges, and so on. But however, single true treatment, it's rare with us. The patients from abroad are coming to us. They have a largely or totally destroyed dentition. They need a complete dental rehabilitation. We have made it our task, our mission, to offer patients in Europe fixed, implant-supported dentures at affordable prices. We want to democratize the implant care. Everyone should be able to offer implant-supported teeth, not only those with well-filled bank accounts. That's why people are flying to us, to Dentprime. But we want them to stay only 5 days. Of course, corresponding trips are necessary for bone grafting, implantation, and final restoration. But treatment stage should be not longer than 5 days. And between the next trip are 6 months. To achieve this and to survive this pressure as a team, all working process has to run smoothly and to be trimmed for highest efficiency. Therefore, we have complete in-house lab with many 3D printers, CAD cams, and sophisticated equipment. All workflows are completely digitalized with CBCTs, tree-shaped networks, and navigated implantology via surgical drill guides. The restoration with highest patient acceptance on the toothless jaw is the immediate loading. 6 implants in the upper, 4 implants in the lower, all on TRI. The matrix implant allows us to achieve even better aesthetic results through the pink and the soft tissue level, and give us the opportunity to make the results much better and faster. We inserted, together with the dream team of TRI, over 30 implants for 2 days. There was some single crowns, bridges, bar constructions, and of course, all 4Ks. Here's our patient. We made CBCT for planning, a wax trim with some measurements. We scanned this wax trim in order to digitalize the height and the position of the bite. I prepared also the due guide and begin with the operation. Edentulous upper and partly edentulous lower jaw, fixation of the due guide and drill through it. After that I remove it and drill to the end shape with already prepared position, location, and depth. The insertion of the matrix implant is very easy because you don't have to worry about the position of the internal hex or index in this case, compared to every other implant system. And this saves a lot of surgical time. After small bone graft and connection to healing caps, the flap was closed. We did the same with the lower jaw, but instead of 6, we inserted 4 implants and connected the scan bodies. The scan bodies can be also used as a conventional transfers. On the X-ray, you are able to see that we inserted the implants in the classical way for all on 3. The laboratory part is also very interesting. The colleagues align the scan bodies with the intraoral scan in the order to transfer the position of the implants exactly into the software. They are preparing the bridge constructions and shaping the emergency profile. In this way, the soft tissue will be formed after the inserting of the provisional. They're using the wax trim for orientation to align the intraoral scan to the face picture, inserting the construction in virtual articulator, trying the movements of the lower jaw, and checking the contacts, which is also very important for the success. After quick milling process, the provisionals are ready. We did actually models because it was our first case, but in the future, I believe we'll work model less with matrix. The final insertion was done by the prosthodontics, the checking contacts, the movements, and the happy feeling of the patient. Firmly fixed, beautiful teeth with a top chewing function, and finally, affordable. For our patient, this is indeed life-changing. With Matrix, we're doing it even better. And I'm very glad that I had this possibility to be part of the development team of the Matrix. Thank you very much.
Thank you very much for this great presentation. We are glad to have you in this Matrix team, and it's a pleasure to work with you, to share with you your outstanding knowledge in the surgical way. There are some questions. Where do you see the main advantage of the matrix system?
We don't have a time with the patient, and the most biggest advantage for us is the time saving during the implantation, the chairing time, and the biggest efficiency.
And what is the time saving? I mean, in surgical way.
You don't have to fix this, to lose the time, to make the right angulation for the abutments, to inserting the abutment, to connect them. This costs a time.
Yeah.
Normally, maybe 10 minutes in the jaw. And after 10 patients, after 100 patients, it's a lot of time.
Okay, and so far in this case you were fully going on bone level matrix implants, and I mean we saw today a lot of times a tissue level implant, and I know that you placed, you told us in this 3 days we had the chance to work together and see this edentulous patient, and also 3-unit bridges we saw and solved. So you were placing one patient, I think the first one in the morning, and you said afterwards that was the first tissue level. And so
Yes,
why it took you I don't know 15 years to place the first tissue
I
level?
didn't have this possibility to touch the matrix.
Okay.
I'm changing now, maybe the mind.
That was my next question. Will you change to the matrix as your main implant system?
When I'm looking to the benefits, I cannot tell now.
Okay. I have one more question about this angulated placed implants. I did a little bit ask the same question to Joel and Joa. What do you think with a tissue level implant, normally in an angulated 45-degree situation, all-on-4 technique, it's a bit of a problem to have this emergence profile of a tissue level implant, but with the matrix, with this concave design, can you think about like that you have not the problems that the bone is overstanding, because normally we add the abutment to come out of the bone area, especially on the distal area?
Actually, it should be more difficult with the bone level implant, because I will make some unsure thinking about the connection between the surface of the connection between the bone level and the new construction. If there will be not a small gap, who will be irritatable for the bone. And now with the tissue level implant, that will be more safe for this kind of construction, in my opinion.
Okay, thank you very much again for this great presentation. Here is your 1,000 millionth implant.